There are 5 medical tests that millions of people over 60 get every single year. They're considered routine, they're considered responsible. Your doctor orders them almost on autopilot. And the United States Preventive Services Task Force, the very organization that sets screening guidelines in this country, has published evidence showing that for older adults without symptoms, several of these tests cause more harm than they prevent. I'm not talking about rare edge cases. I'm talking about documented cascades where a single routine screening in a healthy 75-year-old led to follow-up procedures, surgical complications, and outcomes that were worse than the condition the test was looking for. I'm Dr. James Wilson. I've spent years studying the medical literature on aging, screening guidelines, and what actually extends quality of life after 60. This channel exists to translate that research into plain language you can use at your next doctor's appointment. Today I'm walking you through all 5 tests, what the evidence actually says, and I'm giving you a 5-question protocol at the end that will completely change how you navigate medical decisions from this point forward. But I'm not starting with the tests themselves, because if I just hand you a list, you'll write it down and leave, and you'll miss the one concept that makes everything I'm about to say actually make sense. You need this concept first. Without it, the list is just information. With it, the list becomes a decision-making tool you'll use for the rest of your life. Stay with me, let me paint a scenario for you, because this illustrates what happens when screening runs on autopilot. Imagine a woman, let's call her Gloria. She's 76, retired teacher, lives independently, drives herself to the grocery store, to church, to her grandchildren's soccer games every Saturday. Sleeps well, eats well, takes a blood pressure medication and a statin. That's it. No major complaints. Feels good. She goes in for her annual physical. Her doctor, a good doctor, a thorough doctor, looks at her chart and says, "You're overdue for a colonoscopy. Let's get that scheduled." Gloria hesitates. Her last colonoscopy was at 67, completely clean. No polyps, no family history of colon cancer, nothing. But her doctor says it's routine. It's just being careful. So she agrees. The night before the procedure, she starts the bowel prep. If you've done this, you know. You drink a large volume of liquid designed to completely empty your colon. It's harsh. For a healthy 45-year-old, it's unpleasant but manageable. For a 76-year-old woman on blood pressure medication, it can be dangerous. Gloria wakes up the next morning confused, dizzy. Her legs won't cooperate. Her daughter finds her sitting on the bathroom floor, unable to stand. She calls 911. At the emergency room, they check her labs. Her sodium is critically low. Her potassium is dangerously depleted. Her heart rhythm is unstable. The bowel prep flushed out her electrolytes so aggressively that her body couldn't compensate. Gloria spends 4 days in the hospital. She never has the colonoscopy. And the condition that put her there wasn't colon cancer. It was the test. Here's what makes this scenario so important. Scenarios exactly like this one are documented throughout the medical literature. A 2019 analysis published in the Annals of Internal Medicine found that the rate of serious adverse events from colonoscopy, including perforation, significant bleeding, and cardiovascular complications, increases substantially in adults over 75. And the benefit, the likelihood that screening will catch a cancer that would actually shorten that person's life, decreases with age, because many of the cancers found in asymptomatic older adults are slow-growing. They would never cause symptoms. The person would die with cancer. Not from it. Gloria didn't need that test, but nobody did the math in the room with her. Comment routine if you've ever had a medical test that felt more like a checkbox than a conversation. I want to see how many of you have experienced this. Your experiences matter here. Now here's the concept I mentioned, the one you need before the list makes sense. I call it the screening math shift. When you're 50 years old, screening works beautifully. The math is simple. You find a small cancer early, you treat it, and you potentially buy yourself 30 or 40 more years of life. The reward is enormous. The risk of the screening itself is small relative to that reward. It's a clear win. But after 60, 3 things change simultaneously, and almost nobody talks about all 3 together. The first shift is overdiagnosis. Modern imaging and lab technology is extraordinarily sensitive. It can detect abnormalities that are, biologically speaking, barely significant. Tiny tumors that would never spread, slight blockages that have been stable for years, mild bone density changes that don't predict fractures. These findings are real. They show up on reports, they have clinical names, but many of them would say king, never cause a problem in the person's remaining lifetime. The research term is overdiagnosis, and in older adults, it's not a rare occurrence. A landmark study in the British Medical Journal estimated that in certain cancer screenings for older adults, overdiagnosis rates can reach 40 to 50%. That means nearly half the cancers detected would never have caused harm. But here's the problem. Once a finding appears on a medical report, the system doesn't have a leave-it-alone option. It has a treatment pathway, and that pathway activates regardless of whether the finding was actually threatening your life. The second shift is treatment tolerance. Your body at 75 does not recover from procedures the way it did at 55. That's not a failure, that's physiology. Anesthesia takes longer to clear. Surgical wounds heal more slowly. The immune system is less robust against hospital-acquired infections. Kidney function is often already reduced, making you more vulnerable to contrast dyes and aggressive medications. A procedure that a 55-year-old bounces back from in 10 days can mean 8 weeks of recovery for a 78-year-old, with real risk of complications along the way. Published data from the Journal of the American Geriatric Society shows that post-operative complications in adults over 75 are significantly higher than in younger patients undergoing the same procedures, even after adjusting for baseline health status. This isn't about being frail, it's about biology. The third shift, and this is the one that concerns me most, is the cascade effect. One test finds a small abnormality. That abnormality triggers a follow-up scan. The follow-up scan is inconclusive, so it triggers a biopsy. The biopsy confirms something that may or may not be clinically significant, but now it's in the chart. A specialist recommends treatment. The treatment causes a complication. The complication requires a hospitalization. The hospitalization leads to deconditioning, loss of mobility, loss of independence. And the person who walked into their annual physical feeling perfectly fine is now navigating a medical crisis that started with a test they didn't need for a condition that wasn't threatening their life. This cascade is not theoretical. It's documented. Researchers at Yale published a widely cited paper describing the cascade effect in older adults, showing how a single screening test can trigger a chain of interventions with cumulative risk that exceeds the risk of the original condition. That is the screening math shift. And you need to understand it before we go through these 5 tests, because it's the reason each one of them deserves a conversation rather than an automatic yes. Comment math shift if this concept clicked for you. I want to know. All right, let's go through them. 5 routine medical tests that deserve serious reconsideration after 60. I'm giving you the evidence for each one, and I'm telling you what to do instead. Test number 1. Routine colonoscopy after 75 in average-risk adults. I already told you what happened in Gloria's scenario. Let me give you the guideline directly. The United States Preventive Services Task Force, the USPEF, recommends against routine colorectal cancer screening for average-risk adults over 75 who have had prior normal screenings. For adults 76 to 85, they say screening should be an individual decision, not an automatic one. After 85, they recommend against it entirely. The reason is straightforward. The risks of the procedure: perforation occurs in roughly 1 in 500 colonoscopies, and that rate increases with age, begin to outweigh the benefits when the cancers being detected are predominantly slow-growing and unlikely to cause harm within a person's expected lifespan. What to do instead? Ask your doctor about non-invasive alternatives. The fecal immunochemical test, called FIT, is a simple stool-based screening that can flag genuine warning signs without any procedural risk. If you have symptoms, blood in your stool, unexplained weight loss, persistent changes in bowel habits, that changes the equation entirely. Get evaluated, but routine screening in the absence of symptoms or risk factors? That's a conversation, not an automatic appointment. Test number 2. Aggressive PSA testing in men over 60 and routine mammography in women over 75 without elevated risk. I need to be precise here because this one is nuanced. I am not saying never screen for cancer. Cancer screening has saved millions of lives. What I'm saying is that after 60 to 75 in average risk, asymptomatic individuals, aggressive screening has a documented overdiagnosis problem. Let me explain what overdiagnosis means in real terms. Imaging today is so sensitive it can detect cancers that are biologically quiet, tiny, slow-moving, not spreading, not causing symptoms. These cancers are real, but they are not threats. You would live alongside them comfortably. You would never know they were there without the scan. But the moment the word malignancy appears on a report, the clinical system activates. Biopsies, referrals, treatment recommendations, and those treatments, radiation, surgery, hormonal therapy, carry real side effects. Fatigue, incontinence, pain, loss of quality of life. Research published in the New England Journal of Medicine has shown that a substantial proportion of prostate cancers detected through PSA screening in older men are clinically insignificant, meaning they would never cause symptoms or death. Similar findings exist for mammography in women over 75, where studies have shown that many detected cancers would not have affected lifespan, but the treatments caused measurable harm. Now imagine someone like a 79-year-old man, sharp, independent, still active. A slightly elevated PSA leads to a biopsy, which confirms low-grade prostate cancer. His urologist recommends radiation. He trusts the recommendation. Within a year, he's dealing with chronic urinary problems, fatigue, and significantly reduced quality of life. The cancer that was detected? It was the kind that grows so slowly he almost certainly would have lived alongside it without any problem. That's not a hypothetical pattern. It's a documented one across the urological literature. What to do instead? Have an honest, specific conversation with your doctor about your risk profile. Family history, genetic markers, symptoms, prior results. If any of those flag elevated risk, screen. But if you're average risk with no symptoms, ask this question directly. If we find something, what would we realistically do about it at my age? And would the treatment improve my life or my lifespan? That single question often changes the entire conversation. Comment your age and whether you've had a PSA test or mammogram recently. I want to see where people stand on this. Test number 3, routine cardiac stress testing without symptoms. This is the one that surprises people. It sounds so logical. You're 72, your doctor says, let's just make sure the heart is okay. You get on a treadmill, or they give you a pharmacologic agent that temporarily stresses your heart, and they monitor the response. Here's the problem. In people without cardiac symptoms, stress tests have false positive rates that can reach 40% or higher in certain populations. Published data in the Journal of the American College of Cardiology has documented this repeatedly. That means in nearly half the cases, the test flags an abnormality when nothing is actually wrong. But medicine can't shrug at an abnormal finding. That false positive launches you into the next step: cardiac catheterization. A catheter threaded through your blood vessels directly into your heart. This is not a casual procedure. Risks include bleeding, vessel damage, arrhythmia, contrast dye reactions, and in rare cases, the procedure can trigger the very heart attack or stroke you were trying to prevent. And if the catheterization finds a partial blockage, which is extremely common in adults over 60 who have no symptoms, you may end up with a stent. Here's where the research gets striking. The ischemia trial, one of the largest and most rigorous cardiology trials ever conducted, published in the New England Journal of Medicine in 2020, enrolled over 5,000 patients with stable coronary artery disease. They compared invasive intervention, stenting and bypass against medical management, medications plus lifestyle. The result? In patients with stable disease, the invasive approach did not reduce heart attacks and did not extend life compared to medication and lifestyle management alone. Let me say that differently. The stent in patients with stable disease didn't outperform the pills and the daily walk, but it carried real procedural risks, and then a lifetime of blood thinners with their own bleeding complications. So the cascade looks like this. You feel fine, routine stress test, false positive, catheterization, stent, blood thinners, ongoing monitoring, and statistically, you are no better off than someone who managed the same condition with medication, exercise, and regular follow-up. What to do instead? If you have no chest pain, no unexplained shortness of breath, no dizziness during activity, routine stress testing is searching for problems in a population where findings are common but intervention doesn't reliably help. Focus on optimizing the risk factors that actually move the needle. Blood pressure control, cholesterol management, blood sugar, physical activity, sleep. That's where the meaningful gains are. Test number 4. Routine bone density DEXA screening with automatic medication. Let me be careful with this one because osteoporosis is real, and hip fractures in older adults are devastating. Falls are one of the leading causes of disability and death after 60. I am not questioning the reality of bone loss. What I'm questioning is the automatic pipeline that often follows a DEXA scan result. Here's how it typically goes. You get a DEXA scan, it shows reduced bone density. Your doctor prescribes a bisphosphonate, medications like alendronate or risedronate. You take them for years, assuming you're protected. But long-term bisphosphonate use, beyond 3 to 5 years, has been associated with a rare but serious condition called atypical femoral fractures. These are spontaneous stress fractures of the thigh bone, the very bone the medication was supposed to protect. Published data in the Journal of Bone and Mineral Research has documented this paradoxical effect. Additionally, these medications carry a risk of osteonecrosis of the jaw, painful bone deterioration that is difficult to treat. Meanwhile, the single most effective intervention for preventing fractures in older adults isn't a medication, it's fall prevention. A Cochrane systematic review, the gold standard of evidence synthesis, found that exercise programs focusing on balance and strength training reduce fall rates in older adults by approximately 23%. Studies specifically on Tai Chi have shown fall risk reductions approaching 50%. Removing tripping hazards from the home, installing grab bars, having regular vision checks, reviewing medication side effects that cause dizziness, ensuring adequate protein, calcium, and vitamin D intake. These interventions reduce fracture risk meaningfully, with zero side effects. I'm not saying never take medication for bone health. If you've already had a fracture, if your T-score is severely low, if you have specific risk factors, medication may be appropriate and important. But a routine DEXA scan leading to automatic long-term medication for an active 74-year-old who has never broken a bone and is otherwise healthy, that deserves a conversation, not a foregone conclusion. What to ask your doctor. Before we talk about medication, can we review my actual fall risk factors? What's the fracture risk reduction from this medication compared to a structured fall prevention program? Test number 5. Asymptomatic carotid artery ultrasound screening. This is the one most people have never even considered, and based on the evidence, it may be the most consequential on this list. A carotid ultrasound checks the large blood vessels in your neck that carry blood to your brain. The logic sounds airtight. If we find a significant blockage, we can surgically remove it and reduce stroke risk. Simple. The reality is far more complicated. The surgical procedure used to treat a carotid blockage, called a carotid endarterectomy, carries a 2 to 3% risk of causing a stroke during or immediately after surgery. In older adults with additional health conditions, that risk climbs higher. Published data from the Cochrane database of systematic reviews has confirmed this risk profile. The USPOF explicitly recommends against screening for carotid artery stenosis in asymptomatic adults. Their analysis concluded that in people without neurological symptoms, the risk of surgical harm outweighs the benefit of detection. Here's why. Many adults over 60 have some degree of narrowing in their carotid arteries. It's been there for years. Stable, silent, not causing problems, but when you screen for it routinely, you find it. And a well-meaning surgeon recommends fixing it. And the surgery to fix a blockage that was never causing symptoms can, and sometimes does, dislodge a fragment of plaque that travels directly to the brain. The documented outcomes in the medical literature are sobering. People walking into a routine screening appointment feeling fine and leaving on a fundamentally different health trajectory, not because of the blockage that was found, but because of the intervention that followed. What to do instead? If you have no symptoms of stroke or TIA, no sudden vision changes, no facial drooping, no arm weakness, no sudden severe headache, routine carotid screening is generally not recommended. The far better investment is in controlling the modifiable risk factors that actually drive stroke. High blood pressure is the single largest contributor. Blood sugar management, smoking cessation, atrial fibrillation detection and treatment, regular physical activity. If you do experience any neurological symptoms, even briefly, even if they resolved, get evaluated immediately. That changes the entire equation. I promised you something you could use at your next appointment. Here it is, 5 questions. Write them down, put them in your phone, bring them to every single visit. Question 1. What is the false positive rate of this test in someone my age? This tells you how likely the test is to trigger unnecessary follow-up even if nothing is actually wrong. Question 2. If this test finds something, what are the realistic treatment options for someone my age and health status? This forces the conversation toward outcomes, not just findings. Question 3. What is the procedural risk of any treatment we'd likely pursue? This is the question most people never think to ask. Every procedure carries risk. You deserve to know it before you consent. Question 4. What happens if we monitor this instead of treating it? For many conditions found in older adults, watchful waiting with regular monitoring is a legitimate and often superior strategy. Question 5. What is the most effective non-invasive intervention for this condition? Because very often, as we've seen with bone health, cardiac health, and stroke prevention, lifestyle management and medication outperform surgical intervention with far less risk. Any good physician will welcome these questions. They will respect you more for asking them. And if your doctor dismisses these questions or makes you feel difficult for raising them, That is important information about whether that doctor is the right fit for your care. Comment 5 questions if you're saving this protocol. I want to know how many people are going to use it. Now let me address what some of you are thinking. But what if the test catches something real? What if I skip a screening and miss a cancer that kills me? That's the right question. And here's the honest answer. I am not telling you to refuse all screening. I'm telling you that screening after 60 should be a decision, not an automatic process. If you have symptoms, family history, genetic risk factors, or abnormal prior results, screening is absolutely appropriate. The research I've cited applies specifically to average-risk, asymptomatic adults. Your risk profile matters, and the conversation about whether to screen should include your priorities, your health status, and your understanding of what happens if something is found. My doctor is the expert. Shouldn't I just do what they recommend? Your doctor has training and experience you don't have. That's valuable. But your doctor also sees 30 to 40 patients per day. They follow guideline protocols that don't always differentiate between a robust 72-year-old and a frail 82-year-old. And screening guidelines themselves are evolving. The USPVF updates its recommendations regularly, and the trend over the past decade has been toward more caution in older adults, not less. Bringing these questions to your doctor isn't challenging their authority, it's participating in your own care. The best physicians I've encountered welcome this. Are you saying medicine is doing more harm than good? No, medicine is extraordinary. Screening has saved millions of lives. Surgical interventions are miraculous. What I'm saying is that the tools that work brilliantly at 50 sometimes need to be recalibrated at 75. The goal of healthcare after 60 shouldn't be to generate findings. It should be to protect and extend what matters most to you, your independence, your energy, your ability to do the things you love. Sometimes that means doing less, not more. And that takes more wisdom, not less. Let me bring this back to where we started. Think about Gloria's scenario. A 76-year-old woman who walked into a routine appointment feeling fine and ended up in the hospital for 4 days because of a test she didn't need for a condition she didn't have. That cascade was preventable, not with better medicine, but with better questions. If someone had sat with Gloria and said, "You're 76. Your previous screenings were clean, you have no symptoms and no family history. The guidelines actually suggest we can skip this one, but let's talk about a simple stool test instead." If someone had done that math in the room with her, Gloria would have driven herself home that afternoon, would have made it to her grandchild's soccer game on Saturday, would have continued the life she was quietly enjoying. That's what I want for you. Not less medicine, better medicine. Medicine that accounts for who you are, how old you are, what you value, and what the evidence actually supports. You now have the 5 tests. You understand the screening math shift. You have the 5-question protocol. Use them. Bring them to your next appointment. Advocate for yourself. Because nobody else is doing the math in the room with you. If this gave you a new way to think about your healthcare after 60, subscribe to this channel. I publish research-backed, plain-language health content every week. Medical guidelines change, new evidence comes out, and that evidence takes years to filter into your doctor's office. I bring it to you now so you can make informed decisions, not just follow the checklist. Share this video. Send it to your spouse, send it to your parents, send it to anyone over 60 who has a doctor's appointment coming up. Those 5 questions alone could change the trajectory of that appointment. And leave a comment. Tell me, have you ever had a routine test lead somewhere you didn't expect? Have you experienced the cascade effect? Your story might be exactly what someone else needs to hear before their next visit. Comment "watching out" if you're going to bring these questions to your doctor. Comment "been there" if you've experienced unnecessary follow-up from a routine screening. Comment "sharing" if you're sending this to someone who needs it. Take care of yourselves. Protect your independence. Ask the questions. And remember, after 60, the goal isn't to find everything, it's to live well. I'll see you in the next video.